on sleep medicine. We'll be talking about obstructive sleep apnea, several aspects of its management. We have some very eminent speakers amongst us to enlighten all of you with management of OSA skills. We have Dr. Simab, Dr. Kamal, Dr. Nimish, who all will be sharing their experience with you. I would like to begin our session with the talk on cardiological comorbidities and its association with OSA by Dr. Kamal Sharma. Dr. Kamal Sharma is a senior interventional cardiologist. He has a wide experience of angioplasty, cardiological procedures like stenting, valvuloplasty, implanting pacemakers, and pediatric interventions. Currently, he is an associate professor in cardiology at the UN Mehta Institute of Cardiology and Research Center at Ahmedabad. He is the head of cardiology at Sal Hospital, Ahmedabad, and an interventional cardiologist at Sanjeevani Hospital. He is an principal investigator in several trials like Paradigm, Atlas, TIPS, Seraphine, and Canvas. He has 205 publications and more than 8,500 citations to his credit. And definitely, he deserves to have been awarded the Excellence Teacher Award by Gujarat University. And he's the author of 8 books and many chapters. I would like to invite Dr. Kamal for his presentation.
Good evening, everyone. Dr. Ravi, thank you very much for kind introduction, and it's a pleasure to be here. I must be the odd man out talking about a therapy, but I think it's so important that a cardiologist looks into this perspective. And what was eye-opening for us was our own paper when we looked at heart failure in patients with obstructive sleep apnea. So we were looking at in our own publication patients with heart failure and looked at their sleep study parameters, and then we found out how predominant this disorder was, not only as an association, but also in terms of the etiology. When you start correcting this, refractory hypertension, refractory heart failure, diastolic heart failure, all are basically precipitated, triggered, modulated, and are responsible for CV outcomes. Most of these patients don't end up with complications primarily per se of OSA, but most of the times they are struck badly because of a cardiovascular outcome because of this. So triumvirate of health is essential: sleep, activity, and nutrition. As we all know, important role of sleep. And we all know what is OSA. I think I'll be the least enlightened person amongst the elite panel that we have. But just to begin and focus it upon, it's characterized by repetitive episodes of apnea during sleep, which is defined as cessation of respiratory airflow for 10 seconds or more, while hypopnea is reduction of the airflow by at least 30%, lasting for 10 seconds or more, with an association of drop in oxygen saturation or arousal of sleep, which you can have two types, as we all know. It can be central or obstructive or open and closed airways. So hypnogram of normal sleep and sleep disrupted by OSA would very much look like this. And this is what the sleep specialist would look out into the parameters when the patient is being analyzed for, when we hook up a patient for sleep study. This is the parameters that they analyze across. When you look at the prevalence, it's a globally challenging disorder. And when you look, it's a predicted paper from the Lancet in 2019, which looked at India. And in India, AHI more than 5 events per hour is expected to be present in 52 million populations of adults. That's a huge number. So if you look at globally...
Okay, just one second, by saying my speaker is not working.
Yeah, Dr. Nimish. Okay. So, so AHI more than 15 events per hour would be 29 million. And that would something be like what you find in across USA. And this, I am sure, is underestimation, definitely not overestimation. The pathophysiology, of course, is the upper airway, closed, hypoxemia, hypercarbia, arousal, upper airway open, and then again the sleep apnea cycle of the sleep physiology, as we know. And the basic trigger in the cardiovascular system of this would be increased blood pressure and heart rate due to increased sympathetic surge, or the sleep fragmentation, which all will consequently lead into plunging of the saturation, triggering a negative swing in intrathoracic pressure with rise in blood pressure because of increased sympathetic surges. So it's like a patient whose serum, say, adrenaline is always on the higher side during day to keep him awake and aroused in a state when there is sleep deprived of primarily deep sleep, and during sleep to keep him breathing. The common signs and symptoms, hence, are often triggered by snoring, witnessed apneas by relatives, nocturnal choking, restlessness, dyspnea, diaphoresis, dryness of mouth because of mouth breathing, nocturia, drooling, reflux, and common daytime being, of course, somnolence, morning headaches, impaired memory, concentration, irritability, depression, anxiety, libido, or impotence. And when you look at what it contributes to, most often it's the drug-resistant hypertension. This is one of the things that the cardiologists often tend to overlook. As a physician, a lot of times it's not been evaluated. Apart from adding a diuretic for defining a resistant hypertension or adding an MRA, what is missed out is a good sleep study in a patient who's having suspected obstructive sleep apnea. Remember, these are not always all the obese patients. You may have it in short neck patients. You may have it in a short stature patient. These patients may have low or normal BMI. You can find out. And these patients actually in drug-resistant hypertension can be as many as 80%. This is from Logan's paper in Hypertension in 2001. Diabetes in 58%, heart failure 50 to 70%. It was Javari's paper in 1999, and in our own paper, though I've not included it in this presentation today. In the Indians, we found out its prevalence to be more than 50% again. Atrial fibrillation is triggered in 50%, all hypertension 35 to 45%, CAD 30%, angina 30%. So when you look at the intermediary mechanisms that are associated and contributory, apart from hypoxia, reoxygenation, hypercarbia, and thoracic pressure, the intermediate mechanisms are driven by the sympathetic activation, which leads to vasoconstriction, catecholamine surge, tachycardia, impaired vascular variability, cardiovascular variability, endothelial dysfunction, vascular oxidative stress, inflammation, increased coagulation, and metabolic dysregulation, which is mediated often by leptin, obesity, and insulin resistance. So risk of cardiovascular hence translate into all the factors that I discussed above: hypertension, heart failure, arrhythmia, ischemia, and CV stroke. And the effect hence is driven by the on the hemodynamics of the RV and LV. When the upper airway is open, the thoracic cavity would have the volumes running well, but when it's obstructed, there is increased venous return and exaggerated negative intrathoracic pressure, leading to vasoconstriction and hypoxic PA. So these ultimately translate into the chemoreceptor, pulmonary stretch receptor, and baroreceptor, triggering increased sympathetic activity, decreased PNA, and peripheral vasoconstriction, leading to hypertension, increased afterload, heart rate, and myocyte injury necrosis, with development of heart failure, progression of heart failure, and malignant arrhythmia with increased mortality. So this is a scientific statement from American Heart Association, which would make you wonder why, justify why a cardiologist is talking about. It's published in Circulation in 2021, which talks about recommending screening of OSA in patients with resistant hypertension, pulmonary hypertension, recurrent AFib, patients with class 2 to 4 failure, obstructive breathing, excessive daytime somnolence, and in tachycardia or weighty syndromes of survivor of cardiac death in whom sleep apnea is suspected. And also, apart from stroke, clinical equipoise exists with regards to screening and treatment. So this is all the more justified from a cardiologist perspective to be chasing and looking for any obstructive sleep apnea that's present. So the resistant hypertension, pulmonary hypertension, and the AFib, or which is present if any of the other syndromes, if they are present and you have a suspicion, you have to proceed for the diagnostic testing of sleep apnea. 2017 also AHA had talked about recommending the sleep medicine regarding diagnosis OSA, which included clinical tools and the questionnaire and prediction algorithm, though should not be used to diagnose in absence of polysomnography, and either polysomnography or HSAT can be used to diagnose OSA in uncomplicated patients, especially those with negative or inconclusive HSAT should undergo polysomnography, and those with high probability and negative polysomnography, actually you may have to repeat it. So one negative report does not rule it out, and polysomnography should be used rather than HSAT in complicated patients, especially those with significant cardiovascular disease or potential respiratory muscle weakness, like with neuromuscular disorder, documented awake hypoventilation or suspected sleep-related hypoventilation with chronic opioid use or stroke or insomnia or suspected sleep-related movement disorders like restless leg syndrome. The treatment also is being talked about in the 2021 statement from the AHA, which talks about patients with nocturnal angina, MI, arrhythmia, shocks from implanted AICD may be especially likely to have comorbid sleep apnea. all patients should be considered for treatment, and including behavioral modification and weight loss are indicated. Continuous positive air pressure should be offered to patients with severe OSA, whereas all oral appliances can be considered for mild to moderate, and follow-up sleep testing should be performed to assess effectiveness of treatment. So this is again how I was talking about why it's so imperative from a cardiologist perspective. If they are not woken up by 2017 recommendations from AHA, they should now be awake fully, looking at 2021 guidelines. And that makes it imperative that every cardiologist not only learns to understand what OSA can do, and not only that, if it's present and its prevalence being so high, if diabetologists are talking into heart failure and cardiologists are looking at diabetes in terms of SGLT2 in managing heart failure, it's imperative that when they suspect, they involve a sleep specialist to diagnose, treat, and manage sleep apnea. Thank you very much. Over to you, Dr. Ravi. Thank you.
Yeah, thank you, sir. A very enlightening, in a sense, if somebody is actually watching them with risk factors, they will actually understand how huge is the this intermingling of cardiological issues and our sleep problem. It's a huge thing, very well covered by Dr. Kamal, sir. I really thank you for that. Now, I would like to, Dr. Pulkit, I would like to call upon Dr. Cpap. Dr. Cpap, we are again very lucky to have Dr. Cpap as a part of this panel today. He is a senior ENT surgeon, very well known in the field of ENT and sleep medicine. He is currently the head of department of ENT surgery at Inamdar Hospital, Pune, and he is also a consultant sleep specialist attached to KEMH Pune. He is an ENT surgeon at Sahyadri Group of Hospitals with over 25 years of experience, in which he has conducted thousands of surgeries in all fields of ENT and sleep medicine. He is also the founder president of IASSA, with a special interest in sleep breathing disorder, sinus and ear surgeries, and allergy. He has various national and international papers to his credit and is an invited speaker and guest faculty at several national and international conferences across. I would like to welcome Cpap, sir, and really it's an honor to be with you on the same panel, sir.
Thank you, Ravi. At the outset, I'm going to start my screen sharing. Thank you for those words. I'm quite surprised that ResMed put in figures to the number of surgeries. They know very well I'm never into this kind of messaging and the message sent out. Wonderful being here with Dr. Sharma, Dr. Shah. It's always good to interact with all of you all. I'm going to try and, I think I was going through, first let me have the screen sharing. Is that good enough for you all? Full screen?
Yeah, visible, sir.
Yeah. Contrary to what Dr. Sharma said, I think I'm the odd one out. I was just having a quick look at the number of attendees, and there aren't many ENT surgeons here. In fact, I couldn't see any of the ones across India. So if there's somebody from outside, that's good for me. Why am I here? So I am here because there's a lot that's evolved around the years. In the past 15 years that I've been in this field now, specifically in this field alone. And I've been on various platforms with a lot of my colleagues, the chest people, the neurologists, the cardiologist people. And I've been bombarded a lot over the years where I realized that they weren't very wrong. And they probably, the role of an ENT surgeon was not put across, or maybe was not understood in the right manner. So what I'm going to do here today is very, very gently, and I'm not going to get into the nuances of the surgery because obviously nobody's really interested in how I take the suture or what I do and how great am I at this. But I'm going to talk as much as I can evidence-based to try to give you an idea how the role of an ENT surgeon has evolved over the years. So I don't know why this is not moving. Technical issues again. Let me stop sharing screen again and start again. Pulkit, just let me know when you see this.
Sure, sir.
Okay, is that better?
Yeah, now it's visible. The PowerPoint is visible.
Yeah, let me get this on full screen. Yes.
Yeah.
So this is what was the problem that we were facing. ENTs were probably not taking the right kind of interest. We were not really looking into the physiological aspects of the disorder. And I think this goes across the board when you have a a tag of a surgeon attached to you, because there's always that kind of a surgical ego which says that, okay, if something is medical or something where I'm not going to be actively cutting, I'm not going to be very interested. So times have changed now, because when we started looking into sleep apnea and how this was working, the physiological aspects were very important to us. And let me start by saying that, yes, we do acknowledge the fact that PAP machines are the gold standard as of now, documented. But I do want to use the word as of now, because towards the end, I try and tell you how things may need to be changed over the next, say, decade or so. So for all practical purposes, it is the gold standard as of now. And why so? Because this is like what I was telling you, the UP3, which was like the hallmark of all surgeries that was being done, is what actually gave us surgeons the bad name. Because this was an extremely morbid surgery, extremely difficult, in terms of post-op management in many cases. But this was like, just go across and cut everything that you see so that you improve the airway. And it had lots of issues. And the major issue that was there was the fact that initially there was a pretty decent success rate, which kind of declined over time and led to a lot of velopharyngeal insufficiencies. And because you had cut over so much of the tissue, the PAP therapy that was advised post-operatively was probably a little less efficacious. So because of that, we kind of developed this bad name because of this particular surgery. But what has changed now is the complete protocol that we are using. The sleep evaluation has changed. The scopes and things that we have made us find it very easy to go ahead and find out exactly where the level of obstruction is. We are constantly trying to propagate PAP trials. We're not getting out of that, because we need to know and understand how PAP will help us. Because if PAP is going to get rid of the neurocognitive symptoms and the symptomatology, then obviously my surgical improvement and removing the obstruction is going to make it better. And we've got dynamic MRI. So let's not get into the level of obstructions and things like that. We have scopies now. I'm not going to run through the videos, it might stall, but the whole point is we all know that we've got awake scopies as well as sleep-induced natural drug endoscopies and the dynamic MRI now to evaluate. But this is what we've started doing a lot more. So courtesy all the brickbats that were thrown to me on non-ENT national platforms whenever I presented, they kind of told me, Dr. Seema, you're doing a scopy, but you don't know at what level of sleep you're actually seeing the obstruction. So that's when that got me thinking, and we started doing this. We do what is called as an advanced DISE, where there's an intra-procedural PSG going on. And as you can see, on one side, I'm watching the PSG, on the other monitor, I'm watching my endoscopic picture. So I have a pretty decent idea as to at what stage of sleep am I seeing the right obstruction or not. So that makes it a little bit more easier for us to combat those issues which are otherwise, put a question mark on the diagnosis part. With the dynamic MRI now that we have, if you see that the software is so easy, I can see a very clear-cut sagittal vertical obstruction here. And I can also see a very clear-cut axial obstruction, which, because it's an MRI, I can document the AP and lateral collapse at different levels of the vertical plane. And I can actually document the obstruction and the airway at that particular level, which helps me then post-operatively to see what my results are evidence-based. And we are talking only evidence-based now. So post-procedure assessments are evidence-based. They are no longer subjective to say that, oh, my patient improved after this or improved after that. So we do CBCTs, we have volumetric assessments pre and post-op. I'm going to be presenting this data very soon once I have it ready. I have started this CBCT volumetric assessments now, which will tell us pre and post-op. We have radio frequencies now, which make it so easy to open up the airways. The surgical aspects of tackling the nose, which was once upon a time very, very dangerous, now becomes so easy because of, we use nasopharyngeal airways and then pack the nose after nasal surgeries, whereby the entire danger and the risk factor of doing these kind of surgeries, which once upon a time were much more risky. As you can see, so easily I'm keeping a nasopharyngeal airway there, and yet I'm able to pack. So that makes things a lot easier for me. We've got coblations now, which is, as you can see, and I'm not getting into details, but I'm trying to show the audience that This is bloodless work. This is absolute bloodless work with the technology that we have. You can see me just, eat away the nasopharyngeal tissue in an adult also. This is an adult patient with enlarged adenoids where we're opening up the airway. And as you can see, the coblation is absolutely bloodless. All these things have made surgery much easier. The radio frequency improvement on the airway is become much more easier. But now this is the point that I want to emphasize here. My decision making of the palatal surgeries, which is where the bad name had probably come in, has now become very, very, very specific. So if I'm going to give you a schematic diagram. So if I have a palate like this, and if I'm going to go excising this, that is not affecting my airway in any manner. So these are the places where we can use something like this, where we use a simple radio frequency ablation and then go ahead and reduce it volumetrically. So this is something which we were not thinking before about the size and the shapes of the palate. Similarly, if I have a palate like this, I'm not going to be doing that somnoplasty which I showed you, because when I see something like this on a scope and I see that this is obstructing over here, then I have to excise this. So if you can see that I'm seeing the fluttering happening at this level, then shrinking this is not going to be enough. I'm going to have to excise it. So that's how my planning becomes much more simple and easier and specific. So this was what was the classical one that we used to do. And for schematic representation, I'm just going to try to show you how this has evolved. Now, when I pick up the palatopharyngeus muscle, so basic idea of any surgery was to expand this airway, and everything depended on this palatopharyngeus muscle. What the UP3 was doing was just cutting off all this, and we were not addressing this muscle at all. Then we came up with surgeries like the location pharyngoplasty, where we picked this up and brought it till here. Thereby, you can see that the opening of the airway was much better. I'm not getting into the details of the surgery, showing you the principles of how this is improved. We further went on to realize that, okay, that was probably not enough till here. So we started pulling the palatopharyngeus till the pterygoid hamulus. That was the expansion pharyngoplasty. And we brought it till here. Then over a period of time, we again realized that, okay, we can do more and we can do even better. So instead of the pterygoid hamulus, we started and brought it right here up to the pterygomandibular raphe. And that made the entire airway opening even better. So when you see the entire overview of right from what this was to relocation to expansion and to barb, then you realize that now what we can achieve is we achieve a lot more of the airway expansion, which is very specific. And we do this with a proper algorithm. So this is going to be published very soon. This is called the double S algorithm after my name, where I'm again telling you in very brief how it is important to adjust and accommodate what procedures. So it's not a blanket UP3 that was being done at all times. We look for a vertical palate and we look for an oblique palate. Depending on whether there's an anteroposterior collapse, we have a different surgery. If there is a lateral collapse, we have a different surgery. In the lateral collapse, depending on whether we have a thin palatopharyngeus or a thick palatopharyngeus, we have either an expansion or a relocation. So what I'm trying to tell you is the algorithms and the ways of deciding the surgical intervention is now very, very specific, and thereby the results are much, much better as evidence-based, as you can see. So I will not get into that, but even evidence-based, when you go down further into the tongue-based obstructions, we are able to see that we have a lot of procedures here for the tongue-based expansion. Not going to play that again, but what happens is the surgical results of either the RF of the tongue base or the excision in a figure of almost the same with trials, you see that the results when we start excising are much more than what we were doing in the earlier days. So whether it's the tongue base or whatever we are dealing with, and we see the results post-operatively, we compare them. We have proper objective results which are documented. So you can see the RF done here. You can see the opening up of the airway just by doing, you can see the lesion at the tongue base, you can see the lesion at the palate, and you can see the opening of the airway. So it's a science which has gone really, really far ahead. And if I was to just give you broad surgical candidacies, I would still say that yes, we do say PAP is one of the gold standards, but if there is a failure of PAP compliance, which is defined by the books that, okay, it's not being used for 4 hours per night for these many days, and things like that, then definitely there is a role of expanding the airway that we best can. We do use it whenever there's good low BMIs, mild RDIs, and where we, most importantly, what I say is the identifiable site of anatomical obstruction. So if you can identify the site very thoroughly, like we do now, and if you land up giving a young person a CPAP, probably he may not be very happy with it, and you can probably do better at that time in selected patients. Mind my words, I am not talking blanket surgery for all patients. There is limited role. I'll come to that. Definitely poor surgical candidates are those with morbid obesity, alcoholism, less motivated, and obviously many comorbidities. We are not looking into them at all. Now we have multi-level surgeries, we have single-stage surgeries, we have multi-stage surgeries. So the whole idea is a proper counseling where we do not talk about a single one-shot cure or a quick fix. That's where you tend to go wrong. It's a multi-level obstruction. You have to realize that, and it has to be identified at different levels, and it has to be tackled at different levels. Then only you get very wonderful success rates in the long run. And these are documented, they are published. For anybody wanting to see the publications, you can inbox it to me and I will send you all the details. Now, what is now really important to change is the definition of success. Now, this is where I've been trying real hard, not only nationally, even globally, we are working on this right now, that we are still following this definition of success, which was given by Scher et al. Way back in the early 60s or early 70s. But if you look at it now, again, the percentage of PAP failures is not something given by me. That's why I've not even put a percentage to it. But we do know that PAP failures may be startup failures, or they may be long-term dropout failures, which do not manage over a period of time. And this is what has been defined as PAP efficiency. So 4 hours a night for 5 nights a week. But if you look at percentage-wise, you're talking about only 40% usage being acceptable, that too for consistent users. So if you want to look at that, we need to understand what is the definition of success. So when I do a surgery and I find that the patient, okay, so the patient has come to me with, let's say, EDS, he's got uncontrolled BP issues, uncontrolled diabetic issues, he's got maybe sexual impotency related issues. And if I do a surgery and I'm able to reduce his AHI, or if I'm able to get his BP under control, if I'm able to get his diabetes, not by me, obviously by my colleague physicians, if they're able to control that uncontrolled diabetes, that itself is an improvement in the quality of life quotient of the patient. So just because a surgery has not adhered to Scher et al. Criteria by saying that the RDI has not come to that specific level, but yet if the quality of life quotient of that patient has become better, or let's say I do a nasal surgery and the patient CPAP compliance becomes better, that is still improvement in surgical results. It is still improvement in the patient's OSA, the entire paradigm. So that itself bringing down the pressures for PAP usage, this itself are criteria of success. So we need to redefine the criteria of success. And 2 of my very close colleagues on the international front, Kenny and Brian, Brian's from Canada, Kenny from Singapore, we're all working together. And sleep goal is what we are trying to achieve. And this encompasses not just the AHI alone, but we are trying to look at every possible aspect. We're looking at the BMI, we're looking at the oxygenation, we're looking at AHI, we're looking at the life score improvement by quality of life, we're looking at blood pressures, the improvement on the Epworth Sleepiness Scale, improvement of snoring, everything. So when you have a broader outlook as to the improvement of different criteria, then probably your definition of success and improvement of quality of life becomes a lot better. So I definitely agree with both of my colleagues who, I love this statement where they say that, we are trying to de-simplify it from just being an AHI related issue. And we do understand that we are making it a little bit more complicated, but it is time to understand and take a more holistic and realistic, patient-centric parameters into consideration when you start thinking about treating OSA. And having said all of this, this is the caveat that I give out to all my ENT colleagues. So we all know that the pathophysiology of OSA is not so simple. It's got a whole lot of things that are involved over there. And The ENT surgeon is dealing with just this part, which I've highlighted in red. So obviously, as an ENT surgeon, you cannot be dealing with all of this. So we will have our limitations. But what I'm trying to say is that those limitations that we had earlier have been way, way surpassed. We are a very important part of the team that tackles OSA, because there is nobody better than an ENT surgeon who can identify the site of obstruction. He's the one who can help you remove that site of obstruction in well-selected patients. That is underlined and double underlined. It is the ENT surgeon who will be able to help out in improving PAP compliance when you find that a patient's pressures are way too high because his nose is obstructed or his nasopharynx is obstructed. And it is the ENT surgeon who will be very, very helpful in downgrading the severity of OSA, if not curing it completely. So we need to understand this and to, give you a broader sense of it. If you look at what is the research and development and the changes that have happened from 1966, when the criteria were put in, till 2008, they were relatively the same. The surgical techniques were the same. Nothing has really improved. But I got somewhere around 2005-06 is when I entered. A lot of people across the world started getting into this as a subspecialty on a big, big way. And from 2008 onwards till 2017, this is an old slide of mine, but till date, the techniques, the improvement in surgical techniques are phenomenal. We have evidence-based studies. We have a proper, complete evaluation of the airway pre and post-op. We have them documented on the entire radiological as well as post-PSG things. And you have to compare that with the PAP therapy and its improvement in the past so many years. So that remains. There are lots of new machines that have come up, new masks, new delivery systems. So both are equally comparable. What I'm trying to get across here is we are not contesting that it's either this or that. We're saying it's in conjunction. But the role of an ENT surgeon, which was only restricted to UP3, and that's where everybody else tends to think of surgical results as those days of UP3, which are totally passé now. And we have a lot more things. And I would like to end with acknowledgement to my bosses who've actually got me this. Professor Richard Good is from Stanford, USA. Professor Vicini is the guy who's developed the robotic and the barbed pharyngoplasty. And I would just like to, if you can hear the audio, I'm going to play this small 1-minute clip to give you an idea as to what I'm trying to say. Sorry about that. Let's see if this clip plays and if the audio is audible, it's good.
Say again, please. Anything else? Excuse me, madam. This might do the trick. Oh.
Caltex, our staff will do whatever they can
Thank you so much. You're welcome.
to help make your life a little easier.
So thank you very much for patient listening. That clip was given to me by my dear friend Robert Poisson from France, and it highlights the fact that your correct diagnosis is what is more important than what you do. So thank you very much.
Thank you, Dr. Cpap, for an excellent I really thoroughly enjoyed your videos and your whole presentation, sir. You often say things have moved on such a lot from UPPP, and you were very, I would say, you're such a senior person, but you were so modest enough that it's not a lone man's job, sir, and you have your own limitations.
Ravi, so I will come back to that when we do the panel. Let's have the other speakers, but believe me, nobody should be sitting out here and saying OSA is my domain. It doesn't work that way. It has to be a combined effort with everybody, cardiology included. They have not been given their due recognition in this particular disorder. So we'll come to that. Please carry on with the rest of the thing and we'll take it at the panel time.
Sure. Right. So now we'll move ahead to where, we chest physicians tend to be very proud with the fact that, sleep medicine is chest medicine. But Dr. Cpap sir is definitely opening my mind and heart up. So now I'd like to welcome a fellow colleague of mine, Dr. Nimish Shah, who will be speaking on the role of PAP therapy in OSA patient. Like Dr. Cpap very clearly told that PAP is primarily the most important treatment of OSA. Now, Dr. Nimish Shah is an interventional and a consultant pulmonologist. He is a senior consultant pulmonologist currently at Jaslok, Mumbai. He has completed his entire respiratory training in United Kingdom. He has a special interest in interventional procedures, having done more than 300 bronchoscopies, EBUS, transbronchial biopsies, and also carries out several certificate courses in IP if students want to learn EBUS and placing endobronchial balls from him. He is a member of Indian Chest Society, GMC, RCP, American Thoracic Society, European Respiratory Society, and CHEST, and he has been a part of numerous audits and has several research name. I would like to welcome Dr. Nisha to talk on the most important part of treatment, that is the role of PAP therapy in OSA.
Hi, a very good evening to everyone. Thank you, Dr. Ravi, for the kind introduction. Thank you to Dr. Pulkit and Resmed for having me here as well. As Dr. Sheikh laid the ground for me, and I'm very happy he did, is that I think OSA has moved far leaps ahead rather than just being a chest physician's disease where, PAP therapy was considered as gold standard. And I think personalized medicine as it's applicable in most specialties, I think so the same is applicable to sleep apnea as well. And I think it's I think we if somebody thinks that the PAP therapy is the only thing that you need to think about for a patient, I think they're probably in the wrong century. So I'm just going to start screen sharing. So before I start off with my slides, I would just like to make a comment that I think obviously being a chest physician, I have my own biases, but I've always been training my juniors that that if you are a chest physician, you're thinking about sleep and interested in sleep apnea, we do bronchoscopies day in and day out. Just don't close your eyes and just don't think about passing a bronchoscope through the nose up to the vocal cords as just passing through soft tissue. Try and identify your anatomy. Think more of a physician than a chest physician, and probably as a surgeon as well. And I'm not trying to take anything away from the ENT surgeons, but we use a lot of awake bronchoscopies. We use mild sedation, not technically DICE, but a lot of patients who have bronchoscopies done very easily can be identified as high risk for sleep apnea. And it's just simply with the way their airway works, the collapse that happens, and it's just a very easy thing that you don't even need to do extra. You're doing a bronchoscopy and there you go. So that's where I come from. And I think I would like to add in that, PAP therapy remains the gold standard, but there are a lot of surgery is one. Inspire device again, which is the ENT surgeon's domain. There is the Mandibular Splint, and very recently we had another seminar where even I learned that myofascial therapy is also coming back into vogue. So again, for our mildly symptomatic patients who have sort of mild OSA, not so much of the cardiometabolic risk factors, myofascial therapy may actually be of benefit. Mandibular splints again, and also it's now upcoming. And the reason I like to mention this is I was part of the pilot trial for this is the Tesla trial. So what we did was we modified a TENS machine and we applied it to the genioglossus muscle sort of percutaneously without any invasive procedures, and we just adjusted the current on the TENS machine to just make the patient comfortable, and that showed fairly good results in the select population, which was moderate OSA and in women. I think that study is now moving on to the home care setting in England, and hopefully we should have good and promising data. So coming back to my presentation of PAP therapy. So quoting from the AASM, for the implementation of and practical guidelines for PAP therapy, again emphasizing the importance of identifying your patient's goals and taking a multidisciplinary approach for identifying these patients. So again, as Dr. Sheikh quite rightly mentioned that our cardiologists and our neurologists are our big pillars. I mean, as a chest physician, we generally deal with COPD, asthma. We don't really see that many patients who come in with all presentations, but it's the strokes and the heart attacks, and the uncontrolled hypertensives. They are the ones who feed us in to do polysomnographies. So how I'm just going to go through quickly with this flow chart. So when you have somebody with a diagnosis of OSA, you have to identify what their symptoms are, because again, addressing the patient's symptoms and concerns and actually dealing with them helps with compliance. So we all know PAP therapy compliance ranges anywhere between 50 and 60%. And the way to improve this is by actually addressing the patient's needs. So the patient's main complaint is excessive daytime sleepiness. Yes, that's the way your conversation should move ahead in your OPD basis. So if they don't have either EDS, reduced quality of sleep, or hypertension, then obviously your conversation is going to be going into a different tangents, where you're going to emphasize more of the cardiometabolic risk factors. You're going to tell them that more so it's sort of primary prevention, why we need to use this therapy. Whereas if they are symptomatic, and that's where your dialogue will move on to. So then you discuss your treatment options for sleep apnea. So the patient and the clinician have to concur with what you discuss. So if they do discuss sleep apnea and PAP therapy, then you have to then identify whether they have significant comorbidities, and if they do, then you have to put them on PAP. If they don't, then you have to understand that it's very difficult to hook yourself onto so many wires and try a new device, which is a blast of air into your nose or nose and mouth, and trying to expect the patient to say yes, use this is going to benefit you. So again, rationalize between inpatient versus outpatient PAP therapy, and I'll come to who to pick where on my next few slides. If the goals don't match up, then you have to think about alternative therapies. Again, for the mild and non-obese patients, or even moderate and non-obese patients, we've very successfully used custom-made mandibular splints with excellent results. The Inspire, unfortunately, still not available in India. Correct me if I'm wrong. And again, Tesla is one upcoming option. So again, during the PAP initiation and follow-up, educational intervention. So use leaflets, use flyers. We have a lot of companies, and ResMed, I must congratulate them. They're very proactive in this. They will leave you leaflets to explain, to pass on to the patients. Generally when the patient comes into a doctor's cabin, they always have a lot of anxiety. They may not retain all the information, and if you just give them a take-home message with a flyer, it really helps. Because they sit down, they accumulate their thoughts, and it's easy for them to then relate to your conversation when they start reading that. If you're still not making much headway into sort of complying and concurring with what type of therapy, then you have to use an MDT approach, where you may need to get a psychologist or a psychiatrist involved as well, and use behavioral therapy to try and explain to them, because quite often these patients who have severe sleep apnea may have underlying comorbidities, including psychiatric, which is anxiety and depression. And or troubleshoot with interventions of PAP therapy. And I'm again not being biased because this is a ResMed seminar, but I'll tell you that at least in my practice in Mumbai, ResMed has been my lifesaver. When I came back, the ResMed has been the one company which has really helped me out, because putting a patient on PAP therapy, asking them to pay for a trial and then for rental and then purchase, is a big hindrance in private practice, which I'm sure most of us will do. ResMed has always put patients first. They always encourage them to take a trial. They said forget the cost, and then when the patient is good, they comply. We've done the data analysis and the patient's ready for the PAP therapy. Only that's when they push for the sale. So again, congratulations ResMed for that. And again, other few considerations is, patients may have claustrophobia, so you may need to select very carefully. Even a nasal mask can cause claustrophobia. It's a big mask on the face, with a lot of straps at the back. So again, choose your interface very correctly, because you can only get PAP therapy right on the first attempt. So again, a consensus has been reached that, you know, the sort of when I was training, they always used to say mild OSA, you know, go for lifestyle modifications, let them earn their CPAP machine, probably because, you know, it was an NHS based system where you have to rationalize cost with patients. But now the ASM has thankfully come up with a consensus that no, every patient who is symptomatic, be it mild, moderate, or severe, with or without comorbidities, should be given a trial of PAP therapy. So what are the different types of PAP therapy? PAP is positive airway pressure. So so there are basically three types of PAP therapies. One is called a CPAP, which is continuous positive airway pressure. So what the machine does is it just blows so you set the pressure as a fixed pressure, and what the machine does is it just continuously gives you a blow of air. If it goes up to more than 10, I would rather call it a blast of air rather than a blow of air. And obviously things have evolved since, because, you know, you want to try and optimize your labs, you want to optimize your resources. So then came out the algorithms of the APAP, or the automatic positive airway pressure. So the AutoSet CPAP is what it's commonly called as. So what this machine does is it senses your breath, it evaluates what pressure you require, and then based on your pressure requirements, so it delivers variable pressures breath by breath. And the way it does it is it senses the pressure that required in your previous breath and accordingly delivers pressure in your preceding breath. Lastly is you have your Vpap or your bi-level, which is basically giving you 2 levels of pressure. So for patients who have severe sleep apnea, who are morbidly obese, or they have an anatomical variation where they have a lot of upper airway resistance and require a lot of pressure to splint the airway open, you use 2 levels of pressure. So, and generally by rule is if your pressures on the CPAP are going beyond 15-16, it is always a good idea to think about using bi-level, because 15 centimeters of pressure and above, you know, goes into a territory where it's too much of a blast of air. Initially the patients may say yes, that, you know, I'm comfortable with it, because, you know, they start feeling better, but then over a period of time with such high pressures and only on PAP therapy, it sort of starts dropping down. So bi-level gives you 2 levels of pressure. So it gives you, so here your inspiratory pressure. So when you take a when you take a breath in, the machine delivers a pressure. It maintains that pressure, and then on expiration it drops the pressure. But we all know in ICU language, you need a PEEP, which is positive end expiratory pressure. So you need a little bit of airway pressure to keep your airways open. So this gives you 2 levels. So IPAP, which is inspiratory positive airway pressure, and EPAP, which is expiratory positive airway pressure. So it gives you that pressure drop so that the patient finds it easy to breathe out, keeping in mind that you still want to keep your airway splinted open and you don't want your airway to collapse. So it gives you that much of breathing space. So imagine having 15 centimeters of pressure thrown at you and you're not able to breathe out, because the moment you breathe out, there's that blast of air still coming at you. And that's what a lot of patients don't like. Saying that, the newer devices on the AutoSets have what you call as the EPR, or an expiratory pressure release valve. And what that does, it still gives you a little bit of leeway to drop that pressure without actually needing a bi-level. So again, choose your patients carefully, and if you find that the pressures are going very high, you please start thinking about using a BiPAP as opposed to a CPAP. So coming to CPAP, a little bit of history. So Professor Sullivan published his first article in 1981 at the Lancet, where he connected a device to a pressure sensor through plastic tubes and a silicone sealant on the face to move air through the nasal passages. So what he said was that it works as an air splint to maintain upper airway patency during sleep. And that's the diagram. So we've learned about the upper airway anatomy on my previous lecture. So here you have your upper airway obstructing in sleep, and with positive pressure, here you see the plus signs where it opens your upper airway up with CPAP. So again, this was again published in the same paper by Professor Sullivan, where you see the patient has severe sleep apnea. And over here is when the patient was started on 7 centimeters of CPAP. And here you see quite nicely that the patients had very good control in their apneas. Okay, so as I mentioned before, CPAP is one constant pressure as at the set treatment level through the night with inhalation and exhalation. No adjustments for changes in the airway, such as shifts in body position or transitions in sleep stages like REM. APAP has variable pressure delivered in dynamic throughout the night. It varies depending on the patency of the upper airways, is definitely more comfortable as the pressure delivered changes with the needs of the individual. So again, APAPs are again very important in certain types of sleep apnea where you have purely REM related sleep apnea, where your sleep apnea happens predominantly in REM sleep. So when you're in the other parts of N1, N2, N3 sleep, you may not have so much of sleep apnea, and if your machine's trying to still blow air in, it's going to cause disturbed sleep and poor compliance. The other is when you have pure supine sleep apnea. Again, APAP works very well. So there you go. That's the pressure graph of the different forms of pressure during the night. So again, as I mentioned, that the APAP therapy identifies your pressure and verification. Very good for positional or REM related OSA, bariatric patients as well. And again, very important is patients who drink, because we all know that OSA worsens when you consume alcohol. Your upper airway collapsibility is increased, and again, compliance definitely improves on APAP therapy. So again, so I'm quoting this from the AASM, but I have my views on this as well. So what they've said is that we recommend positive airway pressure therapy to be initiated either APAP at home or in laboratory PAP titration studies in OSA with no significant comorbidities. Again, so a little bit of history. So before APAP came in, or just about when APAP came in, there was a big price difference between the two. So CPAP therapy was pretty much half as expensive as autoset CPAPs. So what was traditionally the way we used to do it is give the patient of autoset CPAP, let them use the machine for 3 to 5 days. You bring them back, you see what pressure requirements the patient had, correct, take the 95th percentile and put them on a fixed pressure CPAP. And that used to work very well in 80 to 85% of patients. It's only those patients who had a very sensitive sleep and a lot of fluctuations in the PAP pressures is the ones we used to put them on autoset CPAP. So again, so what they've recommended over here is that if you have comorbidities such as CCF, chronic opiate use, significant lung disease, such as COPD, neuromuscular, yes, all these patients should be titrated in-house because they may have concomitant hypoventilation, which may not have been picked up in the sleep study, and CPAP may not be good enough and they need bilevel. But in general, a straightforward patient with sleep apnea does not need an inpatient titration. I think we have to rationalize our resources and also the patients. So for those who still want to go traditional, a quick slide on how we titrate pressures or how we used to do it. So you always start the patient on a minimum of 4 centimeters pressure. Nowadays, you don't need that because you have the ramp and the I ramp. So the ramp used to be the amount of time you would set for the pressures to go up to your desired pressures on a CPAP machine. And the I ramp is the intelligent ramp where it senses that the patient is still awake. So they wouldn't really, the machine wouldn't deliver higher pressures until the patient's asleep and the airway resistance increases. So prior to that, we used to start the patient on a minimum of 4 centimeters of water. And after 5 minutes, using the help of a polysomnogram, we would define that as more than 2 obstructive apneas or 3 hypopneas or 5 raras or 3 minutes of loud snoring or unambiguous snoring. We would increase the pressure by a centimeter. And that would happen every 5 to 10 minutes until we got to a pressure where there was 30 minutes without any breathing events, controlled breathing, and to also confirm the pressure. We would drop the pressure down by a centimeter to make sure that none of these events are happening again. And that's the way we would fix the pressure. And as I mentioned earlier, that if the patient's manual titration pressures are going to 14 and above, think about bilevel rather than just CPAP. Okay, so coming to masks and interfaces, again, very important because your first consult is going to be really the clincher when you're trying to convince the patient with PAP therapy. So you're going to explain to them that there are 4 types now of masks available. One is your nasal pillow, one is your nasal mask, you now have the cradle mask, and you have the full face mask. And in most patients, a nasal mask is the most effective of treatment. But remember that if the patient's pressures are going higher, you need that little bit of extra space to dissipate the pressure, which is why nasal pillows may not be the right idea for all patients. A nasal mask may be more comfortable, and if you have mouth breathers, despite being on nasal therapy, then you need to use the full face mask. Alternatively, you can also use chin straps for mouth breathers who are very comfortable with the nasal interface, or with patients with claustrophobia, again nasal mask with a bit of a chin strap. So what are the advantages and disadvantages? Uh, so full face mask, less cooperative for patients, higher severity of illnesses, that's when we generally use it. Mouth breathers, edentulous patients, again, it's difficult if you don't have enough, if you don't have teeth, or you're not using your dentures at night. Again, it's difficult to then control your mouth breathing, and hence these patients do better with that. And generally more effective ventilation. So when you have somebody with acute respiratory failure, be it type 1 or type 2, we use PAP therapy, and we know it works very well. It reduces your incidence of putting patients on the ventilator. Disadvantages: claustrophobia, it hinders speaking and coughing, and risk of aspiration and emesis. So again, use these interfaces very carefully. So a lot of our neuromuscular patients who first start requiring PAP therapy may not need bilevel. A little bit of PAP therapy is good enough because they have a floppy upper airway. And again, for them, it's very important to communicate, because a lot of these patients have proximal and distal muscle weakness, and they can't really they use a lot of sign language or digital touchpads to communicate. And again, risk of aspiration is also very high in these patients. So nasal mask, good for cooperative patients, lower severity of illness, not claustrophobic, allows for speaking, drinking, coughing, and secretion clearance, less aspiration risk, and generally better tolerated. Problem: more leaks, effective limited nasal deformities, and blocked nasal passages. So again, this is where Dr. Sheikh's comments was so appropriate. So you have somebody who's on a nasal interface with rhinitis or a deviated septum, and they just can't tolerate it. And that's why you need a multidisciplinary approach for such patients, where you either use nasal and topical corticosteroids, or azelastine with corticosteroids, and they really work well. Or if you need to do a septoplasty to improve compliance, it's not a bad idea. Nasal pillows, again, very good for claustrophobic patients. Least face contact, no marks on the face. Sizing is easier, very lightweight, easy maintenance, lower severity of illness. Again, men with facial hair, it becomes very easy. Allows for speaking, drinking, coughing as a nasal mask. But the disadvantages are, again, blocked nasal passages, not comfortable in higher pressures, and again, a lot of patients don't like the jet coming straight into their nostrils. So benefits of PAP therapy: so when you have good compliance, it reduces your daytime and nighttime blood pressure. You have those nocturnal non-dippers, which then become nocturnal dippers again. Improves your cardiac function in heart failure patients, improve quality of life in patients with heart failure, and decrease your overall incidence of cardiovascular events. In terms of overall well-being, improves your sleepiness and cognitive function, decreases the incidence of motor vehicle crashes. Again, this is something that is not mandated in India yet, but in the West, if you have suspicion of sleep apnea, your driver's license gets revoked until you get yourself tested. You start therapy, you come back to your treating doctor with a 3-month follow-up, where the compliance is checked, your Epworth sleep score is checked, and only then do you get your driving license back. It improves depressive symptoms. So again, it's not only cardiovascular, but it's also psychiatric involvement, very important, and also improves your glycemic control. So what's the evidence behind this? So a very nice paper from Harsh et al., old paper back in 2004, but it just shows you your insulin sensitivity index just 2 days after therapy has gone from 5.75 to 6.79. with a very significant p-value. And after 3 months of therapy, it's gone up to 7.54. So again, improves your diabetic control. And there you go. That's your HbA1c after 50 days, which is dropped from close to 9.5 to 8.5. Again, blood pressure dips. We've discussed this before. And overall risk reduction in stroke patients as well. On a forest plot, you can see it's all positive. So thank you for your attention, and I think we'll take questions at the end. Thank you.
Thank you, Dr. Nimish, for a very excellent exposition. And therapy actually stands for OSC as of now.
Losing your voice, Dr. Ravi. You're losing your voice. Nimish, you need to stop screen share.
Yeah.
Perfect. Yeah, Ravi. Now you should be audible better.
So I was just thanking Dr. Nimish. This
Something wrong with your mic. Something wrong with your... Dr. Sharma, are you there?
Like I think that Imam sir told.
Yeah. Ravi, what I would suggest you, no, that's not your mic, the disturbance somewhere else. What I'd suggest you do, Ravi, is log in and log out and log in again. Yeah, okay, that's good. Try now. Speaking now.
This is yeah. Hello.
That's better.
Yeah. So the point that Dr. Nimish basically he elaborated a very means the whole protocol and the medical management state of the art medical management of OSA, starting from doing all your high level therapies, and everything falls in place. Means that whole different phenotypes of OSA are, we need to keep on identifying them early and offering them the proper positive pressure at the right point of time. So now moving ahead, just prior to our panel discussion, I think I have the last talk, if I'm not wrong, Dr. Pulkit.
Yes, sir.
Yeah, so I have the pleasure of inviting myself to speak. Yeah. My slides are visible, I hope.
Yeah, they are visible.
So I have already spread through the whole presentation for those who read really quick. So now, like what Dr. Nimish told, a lot of things we will advise, we do advise, we keep on advising, but the basic problem with everything that is advised by a pulmonologist, or let's say a physician for that, so that Dr. Cpap doesn't feel offended, is compliance. Basically, how do you manage compliance in PAP therapy? That has been a really tough question to answer, because you might have a lot of fancy therapy, a lot of good technology around, but if the patient doesn't comply with your advice, then it doesn't practically add up to a lot of things. So I would like to refer to this particular article of the treatment of adult obstructive sleep apnea with PAP. They recommend that educational interventions be given with initiation of PAP therapy in adults with obstructive sleep apnea. That is very, very important. It is a strong recommendation. There is also conditional recommendation that behavioral or troubleshooting interventions should be given during the initial period of PAP therapy, let's say the first 1 week. We do suggest clinicians that use telemonitoring guided interventions during initial period of PAP therapy in adults with OSA. A conditional recommendation more so because we in our Indian setups were finding it difficult to have something for the telemonitoring guided interventions. But luckily now ResMed has come up with a very interesting piece of technology to fulfill this conditional recommendation. Now, the compliance and adherence. What is compliance? It is defined as usage for more than 4 hours for at least 5 nights per week. Improvement of symptoms and severity of OSA, the most important goal for long-term adherence. That is what we all want. Now, The problem is most people report discontinuation of positive airway pressure therapy by 3 years. Nearly 20 to 25% of all patients by the end of 3 years will not be using it. So it is really a tough task for the physician to make them comply and adhere to the therapy. What is needed? Adequate education, continuous follow-up, and continuous motivation that you're actually using what is needed for you. Don't skip it. Initial relief might not be the total improvement. So coming to telemonitoring. Now, how do you manage compliance using telemonitoring? Well, the patient uses a particular technology called the AirView technology, in which using a AirSense device with built-in wireless connectivity, already the data center uploads the whole information to the home care provider or the physician. This follow-up can be taken in the clinic, and telemonitoring can be done via the AirView remote prescription monitoring also. What are the key findings on using this particular telemonitoring as far as compliance is concerned? Up to 38% reduction in patient dropouts. There were several studies showing up to 50% reduction also. There was a markedly improved compliance, and there was reduced cost to collect therapy hours. Now, this is a very interesting software. If you have a look at it, not only are you able to monitor the patient, but accordingly, you are even able to change a lot of important settings as if you were practically present over there. You can change the mode, the EPAP, IPAP, the time, the ramp can be enabled or disabled. There practically all the common settings that we do when we are physically present are capable of being done by this particular software. The compliance and therapy reported can also be generated. If people still want a hard copy, it can all be generated in by the use of it. The best part is patient support has been shown to improve CPAP compliance. Ongoing supportive interventions increase the CPAP usage, ultimately leading to a healthier person. Educational interventions, as I have elaborated initially, is a strong recommendation to improve CPAP usage. We have to improve patient involvement in driving home compliance for the machine. Now, what are the essential elements of patient education? We have to talk about sleep hygiene and OSA to the patient, because like Sir showed a very nice advertisement at the end of his presentation, Sabir sir, and it was so relevant because if you don't actually talk or understand to the patient's phenotype of OSA, you might be ending up advising something which is actually not applicable to you. You have to explain them the role of CPAP, its importance. The use of CPAP by a physician, trained technician, or nurse can be explained, and a very good model for demonstration to this patient. Now, initially, this patient education should be done for at least first month of therapy, of which I personally feel first week is the most important, but first month is what is recommended. It helps in promoting long-term adherence. You should try to talk to the patient of what is disease severity, what is the pathophysiology of obstructive sleep apnea, what is the natural course of disease and comorbidities, what are the identified risk factors. Like all of us mentioned a lot of alcoholics and what are the different treatment options, but we have to highlight the importance of not drinking alcohol. What are the treatment options, what to expect from them, how to outline a patient's role in treatment. It is not a one-way traffic. Sleep apnea management is a two-way traffic. We have to address their very valid social and emotional concerns and set goals for them. It is always easier if you keep on giving them small goals, and you have to tell them the consequences of untreated disease very carefully. You have to not scare them off. That is very, very important, what I feel. Now, patient engagement using new technology to improve adherence to PAP therapy, an analysis was done. They compared PAP adherence among patients who were provided active patient engagement technology versus those who received usual care monitoring. Adherence data was analyzed, and a total of 128,037 patients were studied. Definitely a very significant association was seen towards what you call active patient engagement. Almost all of the data shows a huge significance in favor of active patient management. Be it adherence, be it 30-day adherence, be it number of the days required to achieve adherence, or the use of the different modes like CPAP, APAP, or bilevel, if we are actually causing a active patient engagement, we are achieving much more compliance than in the other group. Now, robust therapy adherence rates can be achieved by adding modern technology to usual care. Adopting advances in technology in care management may allow clinicians to more effectively and efficiently treat patients who have sleep apnea. So comes in this particular application, mobile application, My Air, which is active patient involvement, having a sleep data for at least 30 days of that particular patient. Each night of sleep data is scored, and it is very easy to progress to track the progress. The patient can view your My Air score for each of the last 30 days. So it becomes an interactive platform where both the physician and patient are seeing and interpreting it in their own way. Now, what are the critical elements associated with CPAP adherence? See, with pre-treatment, what is the referral source? Is it the patient himself who has come? Is it the bed partner? Is it some other physician who has referred to you? What is the assessment of the patient's knowledge, the perception of the CPAP treatment? You have to involve the bed partner, mostly the wife, that in the education and treatment initiation of PAP therapy. You have to evaluate patient awareness and assess his symptoms. How does the patient handle a significant challenge in his life? Is there active or passive problem solving needed? What are the assessment of his claustrophobic tendencies, like Dr. Nimishwari correctly told? The evaluation of nasal resistance. Patient-centered mask and device selection is very, very important. And now a lot of these molded devices are also coming up. And has there been any exposure to CPAP before initiation of therapy? Now, these are all pre-treatment. Once you start treatment, things like it's very cold, it's very hot. So then comes in heated humidification. Then a regular phone call following the first week of treatment. Assessing proper CPAP use and its outcomes. Assessing how the patient is perceiving that his treatment is going on and what is the symptom-related treatment response. Evaluation of the partner's perception to the treatment, and troubleshooting problems immediately, especially during the first week of treatment, which is most important, followed by the first month. Evaluate for the presence of residual sleepiness, and if present, initiate treatment, and reiterate if presence of residual events are suspected that, dear patient, CPAP, please adhere, please comply. That is the only way that your OSA will be solved. Now, what are the clinical guidelines? A close follow-up for PAP usage and problems by appropriately trained healthcare providers is indicated to establish effective utilization patterns. This is especially important during the first few weeks. It is the standard of care. General OSA outcomes should be assessed in all patients. After initial positive airway pressure, long-term follow-up by appropriately trained healthcare providers is indicated. In patient education, like I told initially, you should explain the severity of the disease, the pathophysiology of OSA, explain the natural course of disease, identify risk factors pertaining to the patient himself, do genetic counseling if there is a strong familial tendency of any metabolic or storage related disorder. What are the treatment options has to be enumerated to the patient multiply, and you have to tell what you as a physician or as a caregiver are expecting from your patient in turn. And once they become a part of the team, the management of OSA becomes very much easier. Now, how do you assess the outcome of OSA? You see whether there is a resolution of sleepiness. You see the OSA specific quality of life measures. You see the patient's own satisfaction or the spouse's satisfactions level. You check for the adherence to therapy, avoidance of factors worsening disease, whether the patient has started following them or not, obtaining an adequate amount of sleep, practicing or not practicing proper sleep hygiene, and whether the patient has actually lost weight. That also shows a very important motivation for OSA management. Now, what are the several common troubleshooting measures? Common things which come up in the initiation of PAP therapy are nasal congestion or epistaxis, which is usually due to an anatomical obstruction or a dry nose, basically. So either you can send them to an for an ENT consultation if you are suspecting an anatomical obstruction, or you can consider saline spray, nasal decongestants, or heated humidification. There is a recommendation for using steroid spray, but I would ask you to use it a bit carefully. Better is to go for heated humidification. What are the benefits of heated humidification? It is available in a lot of the machines that ResMed offers. Up to 65% of nasal CPAP users experience nasal congestion and dryness of the nose and throat. Warm, moist air that humidification provides relieves symptoms of dryness and make the therapy more comfortable. Compliance gains. If patients are started with heated humidity at CPAP initiation, be it a warm word or be it warm air, your patient will be more compliant with your PAP. Now, other common things, very common, skin abrasion. Most possible cause, anatomical obstruction or your mask is ill-fitting. So choose a different interface. Always say there are many options available. Never we should try to depress the patient that you forcibly try to use a mask which is ill-fitting. Another common problem is eye irritation. In that condition, usually it is the blow of air which is going to the eye. So you choose a nasal mask or pillow. See that the mask is correctly fit. And if still the patient is troubled, they can wear an eye mask or use decongestant eye drops. Mouth leaks can be there if the patient is a mouth breather. You check the median pressure in the sleep study report and find a significant leak. In that condition, you choose oronasal masks and use chin straps. Now, what happens when the patient wakes up as the connector tube pushes condensed water in the mouth while sleeping? It is very common, and several patients also tell the key, Doctor, you have advised for a heated humidifier, but now I tend to get all this water in my mouth. So there is something called as a rain out phenomena which is happening. You use a climate line connector. If there is rain out, increase temperature of the tube, which is the first step. If the air temperature is too hot or rain out is still happening, try increase the humidity level. But I would practically advise you is contact your vendor, ask the engineer to come down and have a look at the problem. That will take care of it very easily. Air in the mask feels too warm or too cold. Increase or decrease the tube temperature as per requirement. You have a whole degree from 16 to 30 degrees, which can be set. Thank you. So coming back to our August panel, I illustrated what Dr. Nimish wanted to actually convey, and I was trying to convey the point that how to do it. Now, I think all of us should in ILD management, Dr. Nimish knows multidisciplinary team is the treatment of choice. So I think OSA also, now it is multidisciplinary team with our ENT surgeon, our cardiologist, our respiratory technology provider in the form of Dr. Pulkit, Dr. Nimish, the pulmonologist, and his assistant pulmonologist, all are there on the panel. I would request all to now initiate our panel discussion.
So, thank you, Dr. Ravi. Thank you, Dr. Ravi, for moderating the session so well. So now I'll hand it over to Dr. Seema Sheikh for moderating the panel discussion. Sir, over to you. In the meantime, I'll ask the audience as well to kindly post their questions in the chat box or in the question and answer tab. So I'll ask the panelists to take up the questions as well during the discussion. Sir, over to you.
Yeah, thank you, Pulkit. So it was very nice to listen into everybody, and I'm going to take this opportunity to kind of keep this very informal and try to get out the right points, because from what I always have seen, that we land up giving a lot of information to the people, but they don't really know exactly what to do. So too much of assimilation of information, we need to give out the right messages. So let me try and start off by asking all of you a very simple question. Now we're all dealing with OSA here. Let's say Nimish and Ravi, you get a patient of OSA, because we need to start right from the scratch to get the right message out across. Now, I would like you to answer, and of course also Dr. Sharma for that matter, that when you have seen the patient in your OPD at your first consult, when will you decide, number one, to do the sleep study? Okay. And number two, during your consult and with whatever you have seen, when would you think that you need to send this patient to an ENT physician, ENT surgeon for an evaluation of the airway? And I will come back after you all have finished and try to answer if I see a patient primarily, how would I send it across to my colleague, pulmonologist or neurologist or cardiologist? So let's start with one of y'all. I mean, let's keep this very open so that we get out a right message. You're seeing the patient in your OPD. When do you decide to do the sleep study? And when would you ask for a ENT consult?
Okay, so I'll take that one if that's okay.
Okay.
So basically, patients who generally come to us, a lot of them. So obviously, predominantly all practice are all chest practice. So quite often we start digging out questions about sleep, and I think thankfully, we have had DNB students with us before, and all of them have made it a habit to ask about their sleep. So that's a good start. What we would always look out for is symptomatology of the patient. So snoring, witnessed apneas, dry mouth when they wake up, nocturnal wakenings, nocturia, unrefreshed sleep, early morning headaches, daytime somnolence. So the standard questions of sleep apnea. Quite often, we have our asthmatics, COPDs, ILDs who come in with comorbidities because they've been on steroids, they are hypertensive diabetics. But when I start seeing more than 3 blood pressure pills, when I see that the HbA1c is more than 7.5, 8, and they've been on polypharmacy for that, definitely, even if they don't have any specific sleep symptoms, I would definitely still think about sleep apnea and doing a somnography for that. In terms of when I would get my ENT colleague involved. So definitely, so my part of my standard practice for examination, especially in sleep, would be to look for the Mallampati score, to look for an underbite, obviously to look at the nose. We don't have equipment to do a detailed check, but just look for an obvious deviated septum or nasal congestion, or you can see any visible polyps. Again, tonsils and adenoids. Tonsils, obviously, adult practice tonsils more common. And when you have somebody who doesn't fit the phenotype of OSA, which would be slightly short, fat neck, a little bit of high BMI, and they have adenoids, that's definitely when one indication where I would think about doing a DICE rather than putting this patient straight on PAP therapy. Secondly, for patients who come back to me, so you've initiated PAP therapy, and those patients who are not comfortable.
No, so hold on, Nimish. We'll come to that part a little later. Okay, I'm first trying to get out for the audience as to what would be the sequence. So first would be a sleep study based on the symptomatology, where we're going to give more importance to. Was I audible?
Yeah.
Yeah. Disturbance here. So the symptomatology based on EDS, snoring, and the uncontrolled BP and uncontrolled diabetes, right? That's how you would go ahead. Dr. Sharma, you want to add something from your point of view?
Yeah, I think it's very important from a cardiologist perspective. We tend to look for OSA in patients who are having obstructive sleep apnea symptoms apart if they have refractory hypertension and if they have refractory arrhythmias or recurrent arrhythmias, including atrial fibrillation, or the morphology, as Dr. Nimish pointed out, short neck, low BMI, neck extension movement, or even patients who are refractory heart failure despite optimal therapy. So apart from symptomatology, if you find a patient who's already on 3 drugs for hypertension and still ends up with, in your clinic with blood pressure of 160, 170, that's one subgroup. If patient is in AFib and his LA is not so dilated, that's the other subgroup. And third, if the patient is already on therapies like ARNI, SGLT2, the current line of therapy of heart failure, and he's still symptomatic, right? I 3 days back, I had a patient, obese guy, did an angiogram, came with nocturnal angina, did an angioplasty, successful result. Next day in ICU, he again says, I'm still feeling the same. He ends up with a polysomnography and it's badly positive. So then it's of course referred to the sleep specialist guys. And so these are the guys, they can masquerade as an angina. I mean, that's where our suspicion comes.
Ravi, you want to add on something? You're muted, Ravi.
Sir, practically, like Dr. Nimish and Dr. Kamal told, that, referring There are two things, sir. I'll be very frank. I come from Indore. I'm not in a top tier city. Now, for me to refer to a patient,
Indore is not a small city at all.
no, sir. My point I'm trying to make in a different way, sir. We might be huge population wise, but there is a huge dearth of, like, I got a sleep study done. I prescribed something PAP to the patient. The patient, like Dr. Nimish told, first thing is he should come back. Like, very relevant. Most patients end up with some cardiological issue. Then Dr. Sharma again sends it back ki ye sleep mein kuch to problem tha. Then I think over. I send to ENT person. There are two things which I have to think. Can my person, ENT person, actually offer something more to this patient? Number two, do I have to think of some surgical option? There are, because आपको स्नोरिंग है और आपको सर्जरी कराना है, that in itself is a big thing for a patient to accept, and accept that doctor also advising that particular advice. That is my point.
So here's where I'm going to now try and give you a different perspective. Okay, so we are not talking about the person directly being primed or told about surgery. So we all agree, and it's obvious that everybody agrees that the indications for doing a sleep study are very simple. This is what we've decided. What is your next step that you do? You will obviously want to advise that patient a PAP therapy, right? Now, you are obviously well aware of. Now, let me just share a simple screen. I'm just going to show you a 30-second video, and then I will talk about what I'm trying to show. So see this video here. Can you see this? Do you see this, all of y'all?
Yeah, visible, sir.
Do you see the epiglottis? You see that? This is the epiglottis totally obstructing the airway. It's totally obstructing. This is awake flexible scopy. There is just no place. So the point that I'm trying to make here is that every patient of yours, before you even try a CPAP trial, you need to ensure that the epiglottis is not floppy. Because I see a lot of patients who have come to me with total suffocation on the day of CPAP usage. Because now the epiglottis, which was like this, is like this, and you're pushing in PAP from here, the entire airway is collapsing. So the point that I'm trying to make is, for obstructive sleep apnea, let's not even get into the surgical option now. You're not sending the patient to an ENT for surgery. You're sending the patient just for a simple airway evaluation prior to your PAP starting. Okay. The decision is quite clear. You have a communication with your ENT. So it's like it's a multidisciplinary team. We have everybody together. Everybody knows the reason why the patient is being sent. And primarily, like Ravi said, in private practice, one does not want the patient to be moving 10 places because the patient is going to get lost. He's going to start wondering why so much is happening. So you have a clear indication that we say, okay, you need a sleep study. You come back to me with a sleep study. After the sleep study, if I'm going to initiate you on a PAP trial or a PAP therapy, prior to initiation of PAP therapy, I need to confirm that your airway is good enough for you to take a PAP therapy. That's the reason where an ENT consult comes primarily along with the first consult. And vice versa for me, if I am seeing a patient primarily in my ENT OPD, and I decide that this guy needs a sleep study, and I get a sleep study report in hand, and I find that maybe there is a lot of central apnea. Now, I'm not talking about the symptomatology part. I think even Dr. Sharma said it clearly, Nimish and you, Ravi, all have said it very clearly that we know when the patient needs additional help, right? But if I see a sleep study where I see a central apnea component, which is, let's say, 1/4, and I'm giving very rough figures, say 1/4 the amount of obstructions that are seen on the sleep study, then I would consider that central apnea as significant. And then that's where I would not be looking at removing the obstructive apneas first. I would like to take an opinion from my colleagues, whether he's a pulmonologist, a neurophysician. If I have diagnosed maybe something like a narcolepsy on history somewhere, or I've diagnosed something else where it's not corroborating with the clinical findings, then you need to involve. So what I'm trying to say, and what I've been trying to propagate, is that neither should CPAP therapy nor any kind of surgical even mention should be given before there's a combined consult between two specialists. Somebody needs to look at that airway because it's an obstructive sleep apnea that we're talking about, and somebody needs to look at the sleep study, right? I mean, I hope this is what we can understand. So it's not about, we don't want the patient to be roaming around too much. We will lose the patient. And like Ravi rightly said, if you're going to tell that patient, oh, for snoring, you go to him, he's going to offer you surgery. No, the patient is not going to be offered surgery. The patient is going to be told that you go there to find out at what level is your snoring happening. So you find out from a scopy where the level of snoring is happening, and then you come back to us, and then we'll take a call what we need to do. So this is what I think is more important for all of us to be doing, right? Okay, so now we've done the sleep study, we've done a physical examination, we find that there is some kind of, let's say, partial obstruction, and there's a lot of central apneas. Now let me know from you all, how do you start the initiation for the PAP therapy? What is the kind of counseling that is done? Because this is what they need. See, we're not going to be sending them. So Nimish spoke about mandibular devices. Okay, let's start from there. Which are the ones that you will say, okay, not the ENT, but you need to go to a MaxFax guy, or you need to go to an orodental surgeon or a sleep dentist. How do you take a call on that? Because this is what we need to give out to the people, that, you know, how are you going to deal with the patient? Anybody can take that.
I think for a cardiologist, it's pretty simple. And for us, it's very easy to refer the guy to the sleep specialist. So that's the end of the thing. Right. So it doesn't make, I mean, we know that this, once the sleep study is done and they tell us that there is a sleep disorder, OSA component central or peripheral, whether it's, as you mentioned.
Can I put you on the hot seat there for a minute? So I'm going to ask a very frank, direct question.
Yes.
Like you just gave the example of the guy whom you did an angiography,
yes.
and then you decided that he needs to go in for a polysomnography.
Yes.
Would you ever, and in which condition, if at all, would you prefer to do a PSG first before you do an invasive angiogram?
No, so this guy, what I was talking about is one of the odd man out. You know, he had a refractory angina. Most of the times it would be the other way around. So this is the guy, you know, we could pick up. He was already post angioplasty 5 years back with a fell patent stent and normal biomarkers. We were not suspecting acute coronary, persisted with angina.
I'm not getting to one case. I'm asking
yes.
you.
So most of the times they would actually end up before, you know, most of the guys, that's the reason ResMed would have invited me. But yeah, you can count on most of the cardiologists doing the other way around. You're right. I mean, actually most of them missing it out. You know, the whole purpose is, yeah, most of them would actually be missing it out and thinking, oh, either he's psychological or this is not a cardiac pain, you know, or this is arrhythmia. This guy is just going to pump up more of the anti-arrhythmics or maybe push more anti-hypertensive.
So my question is more specific. Would you be advocating the fact that any cardiology patient that comes to you gets a very detailed clinical history asked about sleep disorders, and would you prefer to do a PSG before you prefer to do any cardiological evaluation?
Before cardiological evaluation, I would say no, but with cardiological evaluation, surely yes. So it's in our part of practice. It's like what Dr. Nimish was saying. His fellows are trained to, you know, pick up from the history. At least couple of sleep histories I in my practice and my medical officers are also told to ask. Firstly, the snoring, the sleep quality, daytime somnolence, suspected short neck, any guy who is high BMI, double chin, you know, again, it's a surrogate marker. People say it need not always go in with the OSA, but that's some of the ways we can actually ask the patient whether you can see the Adam's apple. That's roughly, I tell my fellows in training, can you see the patient's Adam's apple? If you don't, keep your suspicion high. But that need not be, again, a lot of papers on that as well. I have a lady who's 48 kg, 4.11 in height, BMI less than 23, but she is such a bad OSA that if she doesn't take her CPAP, her blood pressure goes to 200. And she is a wife of a commissioner income tax. And unfortunately, I was the cardiologist who actually diagnosed an OSA.
So we all get this, right? Okay, so Ravi and Nimish, to you. Now, after you've done this, let's say you send him to your colleague ENT, you ensured the epiglottis was fine, then you put him on a PAP therapy, you did everything by the book for the first 1 week and 1 month, okay? And the patient comes back to you and says, either you see the reports and you're not very happy, or the patient says they're not very happy. What is your step at that time? Whom do you involve at that time?
Actually, the we have to involve the patient himself. We have to ask him frankly, what were your issues? What did you not have any relief? What were the practical points that you faced? We have to involve the person's spouse or the bed partner of that particular patient, and actively help in problem solving as to what are your apprehensions regarding that. We again need to stress the importance of positive airway pressure therapy, because they tend to take it very lightly initially कि चलो कुछ और हो तो आप बता दो इस टाइप से. तो we have to reinforce that thing. I think that is what I would
So
like.
when you are given that question across to you कि कुछ और हो तो बता दो, what is your answer?
अभी तो कुछ नहीं है, आपको इसी को कॉन्सेंट्रेट करना पड़ेगा. एंड यू हैव टू रीइंफोर्स इट इन अ वेरी, मींस यू कांट बी वेरी dictator in that particular sort of convincing with the patient. You have to have a lot of empathy with him, understand what is his issue. And it's not easy for anybody to actually put a device in sleep if somebody is actually has it in his psychology. So we have to emotionally sympathize with the patient, take a lot of help from the spouse. If you put both the two together and at least ask the patient ki chalo aap at least 4-5 days ke liye laga ke dekho, by that time you will start adjusting to it. You start working with the pressure in pressure out techniques, so that might help increasing compliance.
Okay. So Nimish, anything you want to add on that? And
No, so I think Ravi's just pretty much covered everything. But just to add a note saying that generally it's either the interface or humidification which is an issue, and that's something that we have to ask and sort out. The basic question is, what's the problem? If you have moderate to severe sleep apnea, there is pretty much very rare occasions where you won't be able to take Pap therapy, and it's generally what I've found is it's either the interface, which is the mask, or it's the humidification, which is an issue. And I think that's pretty much of paramount importance.
Absolutely. So now again, add on to the first question that I asked you, when would you want your other colleagues to intervene? Pulkit, please tell me regarding time and tell me some other questions. We'll take them because then we want to stick to time, and I want to give very clear messages, even though it may be very less messages. But let's be very clear in what we send out.
Let's have this last question from your end. Then we have 3 questions from the audience.
Okay. I think you take the audience questions first. That would be better, right? Take the audience questions first. I will come back to that if there is time. It's our moral duty to ensure that we address the other people.
So we have a question by Dr. Arun Kumar. So a patient is having a migraine. Can we suspect of having OSA? If yes, what would be the treatment plan?
So yeah, migrainous headaches can sort of get aggravated because of untreated sleep apnea. We've seen this quite often. We've had proactive neurologists who are also very interested in sleep medicine, and uncontrolled epilepsy and migraines again are comorbid conditions in sleep apnea. So yes, 100% think about it if the phenotype and the symptomatology fits.
I think make sure it's not hypertensive headaches. These patients can actually come with 180 systolics.
Very common, very common. There's one more here about, very important point from compliance point of view, Dr. Ravi. Okay, that is done. How do you decide IPAP and EPAP pressures during prescribing BiPAP therapy? This is from Dr. Beena Modi.
Yeah.
You want to take that, any of you?
Actually, related it is done the therapeutic part of the PhD study. And nowadays, anyway, automated pressure systems are available. So a lot of automatic PAP compliance is checked up by the machine. And as per patient comfort, the newer technology delivers relevant IPAP and EPAP. And anyway, with this new mobile-based application, you can increase or decrease the pressures as per the patient saturation levels and comfort levels also.
So if we can add to that, so there are two ways. So either you can do a bi-level titration manually, which is in hospital or in a clinical environment, or you can do an APAP setting at home. You see your 95th percentile and you fix your pressures, And then if you want, you can either do a day, if the patient's feeling better, then the AHI score on the data download that we get is good enough. If it's not fitting in right, then better to do a polysomnogram on the bilevel pressures to make sure that the apneas and the hypopneas have been addressed.
Okay, there's one more. I can't see the name. It just says Dr. A. But please comment on the efficacy of DICE evaluations from an ENT surgeon point of view and a pulmonologist point of view. So I think the evaluations from the DICE perspective are wonderful now, because like I explained to you, the advancements in trying to figure out exactly at what level the obstructions are is become much more specific. We have it with intra-procedural polysomnographies. We can also combine it with, and by the way, DICE is not like the ultimate goal. Please try and understand that, with the advent of dynamic MRIs, there could be a lot of patients with a lot of comorbidities whom you do not wish to put under DICE, because for DICE, you're literally putting them to near total general anesthesia, and then you're pulling them out, and then you're giving them a kind of an understanding, which is again not 100% absolute, that this is exactly where the obstruction is. And it's a very subjective kind of an evaluation, because there can be inter-observer variability in interpreting a particular DICE. It can also be that if your particular anesthetist has probably put in maybe 1 milligram more of propofol, or a little bit more of drug, that could totally make the collapse much different. So a DICE obviously is one of the wonderful tools. So in the guidelines that we have put out as an association, which we published, we have made it very clear that it's DICE and or dynamic MRI. So dynamic MRI is much more objective many a times, and many a times you probably don't need to go to the level of DICE. You might be able to identify the obstructions much earlier and then take a call on that. But having said that, yes, it's come a long way, and DICE is very, very specific in today's date. I don't know what a pulmonologist may have to offer from a DICE point of view, because I don't think they would be evaluating a DICE. They would be doing a bronchoscopy, like Dr. Nimish said, and that becomes quite important, I would say. I could actually say that rather than send it to an ENT surgeon, maybe you could use your own bronchoscope and have a look at the epiglottis before you do the Pap trials.
So in fact, I'll just add a statement to that, quite rightly said. So I was in Berlin just before COVID hit, and I was in a chronic respiratory failure conference with the ERS, and actually took 3 days extra out to shadow an ENT surgeon in Berlin. And what he said is that, Nimish, I use a flexible bronchoscope to do my DICE. I don't use the indirect laryngoscope, the flexible laryngoscope, because you have the power of suction. So I think it's a very good idea. So if you work in a setting where you either have an adult, or even better, if a pediatric scope, it works very well. You don't have any artifacts, and it's just a very easy thing to do.
That's what I'm using. That's why I said we need to propagate this multidisciplinary approach. That's the only way. Yes, Pulkit, please take on anything more, because I don't see any other questions over.
So there are a couple of questions in the question and answer tab, but due to time constraint, we'll take only one. So the first question is, how important is number of desaturation in diagnosing OSA? The number of desaturation they're asking about.
So I think the rest of the questions are exactly what I was trying to bring out. They're all related to when will you involve a sleep dentist.
Yeah.
I think let's let any one of you all answer the first one, and then we'll take the other three all together.
Fine.
Well, number of desaturations on a proper PSG setting, they can be like your apnea, hypopneas can be counted and classified according to them. Then the severity is decided by those desaturations. And like Dr. Nimish told, that as per your PAP titrations, whenever you're able to obliterate those desaturations with PAP therapy, you'll be able to advise those particular pressures to the patient. So they are the foundation of your sleep medicine. This is the foundation of PAP therapy, basically.
But if I may add on to that, I would really like people to understand that, obviously we're not going to get into the details, but there's level 1 study and there's level 3 study. Level 2 is not that much common. But any one of us, and I think majority of the people in most of the cities are lining up doing level 3, because everyone doesn't have access to level 1. So for all those of you who are doing level 3, please understand a very simple math. that the apnea-hypopnea index, AHI, is calculated with number of apneas, hypopneas divided by the number of hours. Now, the level 3 study does not really tell you the number of hours of sleep. It just tells you the recording on and the recording off. So eventually, the denominator that you're using is much higher. So as a result, your AHI that is reproduced is much lower than what it actually would be. So in short, what you need to understand is that a level 3 sleep study is underdiagnosing your saturation index, the AHI index. Ideally, the saturation AHI would be much higher when you do a level 1. So you must keep this in mind that whatever AHI you see on a level 3, you must probably give it an additional 15-20% when you're calculating in your mind and when you're doing things. It's very important to realize that. The other parts, I think all of them are asking a very simple question: role of orodental therapy, when do you advise intraoral devices, and what is the link between OSA and TM joint? So, what I was trying to bring out, I would just go ahead and simply answer that rather than get into discussions, is the fact that whenever you're dealing with a patient of, say, mild OSA on your polysomnography, whose major issues are probably related to snoring and does not have so much of EDS and other comorbidities that are attached, these are the kind of guys whom you can possibly get away with trying to get the sleep dentist to get involved. But remember that, they have, each one of us as a fraternity has limitations in managing OSA. So you need to understand limitations first. Mandibular devices may sound very fancy. They're very good to be using, but they have very limited role in a very limited situation where it's a very low AHI and a person who has got only purely snoring, where there's probably just very little obstruction in the upper airway region, and somebody who is not willing for even the non-invasive surgical management in mild OSA. So these are ideal candidates, but you have to keep in mind that they will have huge issues with their TM joint, with the masseter muscles, because wearing that device every night is not so easy again in the long run. And a lot of oral dentists will also tell you that they have limitations, although the devices, again, over the years, because I'm working with a lot of these dental people as sleep dentists in India, and now there are quite a few that are emerging, and they are improvising on their day-to-day devices. The only thing that I can tell you is if you go onto the net and look for these kind of devices, you'll find over 324 patented devices across the globe. 324 patented devices across the globe itself should tell you that really not one of them is doing a great job. Because if it was only one, that would be the only one that would be used, and you wouldn't need to patent so many of them. So keep the limitations in mind, but yes, they have a role to play when you're dealing with the mild cases in the beginning.
I think those are the questions that we have received so far, and we are well on time only. So
great. So I would like to, just sign off, let the rest have their, their words and get out very good messages from all of them. But I would like to really thank ResMed for getting an interdisciplinary team right here to be discussing. I would love to be, coordinating more on such platforms, because we need to get the right messages across about the multidisciplinary action in all of this. And it's been a learning experience for me. As always, I always pick up a lot of things. Wonderful presentations by Dr. Sharma, Dr. Nimish, and Ravi. So it's a learning for all of us. So let's try to all together try to get this to be a multifaceted approach. It's just not about any one person, any one fraternity. And the more we get out with proper sleep clinics under one roof, and I'm sure people at ResMed and everybody else is definitely